The musculoskeletal system, which includes bones, muscles, joints, and connective tissues, is essential for movement, posture, and protection of internal organs. Injuries such as fractures and conditions leading to immobility are common across many healthcare settings, especially in aged care, orthopedics, and rehabilitation wards. For new graduate nurses, understanding how to assess, monitor, and care for patients with fractures and limited mobility is vital for promoting recovery, preventing complications, and ensuring patient safety. Fractures can occur due to trauma, falls, osteoporosis, or pathological processes like cancer. They can be classified as closed, simple, open, compound, displaced, non-displaced, comminuted, shattered, greenstick, common in children, or stress fractures. Each type has different implications for healing and management. Nurses must be able to identify the signs of a possible fracture, which include pain, swelling, bruising, deformity, loss of function, and crepitus, a grinding sound on movement. Immediate nursing care for suspected fractures includes immobilizing the affected area, applying cold packs to reduce swelling, and elevating the limb if appropriate. You must also monitor for signs of neurovascular compromise, which can result from swelling, bleeding, or tight casts and splints. This includes assessing circulation, sensation, and movement, CSM, also known as neurovascular observations. When performing neurovascular checks, assess capillary refill, distal pulse presence, skin temperature, sensation, for example, numbness, tingling, and motor ability. Compare both limbs and repeat the assessment regularly, especially after surgery, plaster application, or if the patient complains of increased pain or tightness. Compartment syndrome is a surgical emergency that can occur after fractures or trauma and is characterized by unrelieved pain, tightness, pallor, and loss of sensation. If suspected, escalate immediately. Pain management is another key nursing priority. Administer analgesics as prescribed, and evaluate their effectiveness regularly. Use a pain scale to help patients describe their pain. Postoperative patients may be on PCA, patient-controlled analgesia, or require scheduled pain relief. Uncontrolled pain can delay mobilization, impair breathing, and affect sleep and mood. Surgical intervention for fractures may involve internal fixation, plates, screws, rods, external fixation, or joint replacement. Post-op care includes monitoring the surgical site for bleeding, signs of infection, and proper wound care. Observe vital signs, oxygenation, and neurovascular status closely in the first 24 hours. Reinforce wound dressings as per policy and notify the medical team if there are concerns, such as excessive drainage, redness, or increased pain. Immobility, whether due to fractures, surgery, or chronic conditions, brings significant risks that nurses must anticipate and manage. These risks include pressure injuries, deep vein thrombosis, DVT, pneumonia, constipation, muscle atrophy, and psychological decline. Preventing these complications requires coordinated and proactive nursing care. To prevent pressure injuries, perform regular skin assessments using tools like the Braden scale, reposition patients at least every 2 hours, and use pressure-relieving devices such as air mattresses or heel protectors. Keep the skin clean and dry, use barrier creams as needed, and encourage good nutrition and hydration to support skin integrity and healing. DVT is a major risk for immobile patients, particularly post-op or those with lower limb fractures. Assess for calf pain, swelling, warmth, and redness. Administer prophylactic anticoagulants, such as enoxaparin as prescribed, and use compression stockings or sequential compression devices. Encourage early mobilization as soon as safe to do so. Pulmonary complications can arise due to shallow breathing, reduced mobility, and pain after surgery. Encourage patients to perform deep, breathing exercises, use an incentive spirometer, and sit up in bed or a chair to expand the lungs. Instruct patients on effective coughing techniques and provide analgesia to allow them to take full breaths. Constipation is another frequent issue, often caused by immobility, opioids, and dietary changes. Monitor bowel patterns, provide fiber-rich food and fluids, and administer stool softeners or laxatives as ordered. Encourage mobility and toileting routines to promote regular bowel function. Mobilization is central to recovery from fractures and should begin as early as possible under the guidance of physiotherapy. Nurses support this process by encouraging patients, providing pain relief before movement, using mobility aids correctly, and ensuring safety. Fall prevention strategies include adequate lighting, call bells within reach, non-slip footwear, and supervision as required. Psychological support is often overlooked but critical. Fractures and immobility can cause fear, frustration, anxiety, and even depression, especially in older adults who may fear losing independence. Be empathetic, involve patients in their care plans, set achievable goals, and celebrate small milestones. Provide emotional support and involve family members when appropriate. Patient education is a vital nursing responsibility. Teach patients about cast or splint care, signs of infection or neurovascular compromise, when to seek help, and the importance of adhering to weight-bearing restrictions or physiotherapy exercises. For example, advise not to insert objects inside a cast to relieve itching, and to keep it dry unless it's waterproof. Clear and simple education reduces readmission and empowers patients in their recovery. In long-term care or community settings, immobility might result from neurological conditions, advanced age, or chronic musculoskeletal diseases. Nurses must advocate for mobility-promoting activities like walking groups, chair exercises, and access to mobility equipment. Collaborate with physiotherapists, occupational therapists, and GPs to design care plans that maintain function and prevent decline. Fracture healing is affected by age, nutrition, comorbidities, and lifestyle factors. Ensure patients receive adequate calcium, vitamin D, and protein. Smoking cessation should be encouraged as nicotine impairs bone healing. Monitor healing progress during follow-up appointments, and assist with transportation or referrals as needed. In palliative care, fractures may occur due to bone metastases or frailty. The focus shifts from curative treatment to pain control, comfort, and dignity. Nurses provide compassionate care, manage pain effectively, and support families through decision-making. Involve multidisciplinary teams to address spiritual, emotional, and social needs. Documentation must be thorough, accurate, and timely. Record neurovascular observations, pain assessments, skin integrity, mobility status, pressure area care, and patient education. Use standardized charts and clinical pathways to support continuity of care. Any changes or concerns should be clearly communicated to the team and escalated appropriately. Interdisciplinary collaboration is key to successful outcomes. Nurses work closely with physiotherapists, occupational therapists, dietitians, doctors, and carers. Attend case conferences and handovers, contribute observations, and advocate for your patient's needs. Teamwork ensures holistic and effective care. In summary, caring for patients with fractures and immobility requires a holistic, multidisciplinary approach. As a new nurse, your role is to assess risks, deliver safe care, prevent complications, and support recovery through education, encouragement, and compassion. With time and experience, you'll develop clinical intuition and confidence in managing musculoskeletal conditions across all care settings.